All right. Sorry again to, I'll go ahead and get started.
May give a couple of minutes, Dr. Bar, so we are having a few more participants who may join in.
Yeah, we have a few more just coming in right now, but thank you again for joining us today. I know it's inauguration day, and I didn't even think about the date clash until someone reminded me. It's like, well, your ego is kind of large for you to say that you want to do this at nearly the exact same time. But it was just, I picked a number out of the air, and once we went through the accreditation, I couldn't really undo it. So thank you again for being here. And I just wanted to, the background for all of this is really the reason why we've done this, and we've actually extended it as a free webinar to everyone here, because I think a lot of times sleep as a newer field hasn't really been as ingrained in our thought process when we are speaking to patients. In the traditional model of practice as well, with patients having such a limited amount of time with their physicians and their providers, sleep tends to be put on the back burner, and you after your hypertension, your diabetes gets evaluated, and you've already gone through all the hard work. You don't have any minutes left, and the physician or the provider doesn't really actually have time to go through a sleep history. And what ends up happening is they'll discuss it the next one, and Ambien is what the treatment will be. And because it's hard to get therapists to work on CBTI or cognitive behavioral therapy for insomnia. So I really wanted to create this series just to allow people to think about sleep and how it affects their patients, how it affects their patients' health, and understand that if we do address sleep issues, it actually makes the provider's life and the patient's life a whole lot easier in terms of managing all the other comorbidities. And so we can see how that translates in this series of webinars. This is the first of five. The next we'll cover is insomnia on February 17th, and you all receive a registration invite for that as well. We do it at the same time, 12:30 to 1:30. And the following that, we will have one on OSA, or sleep apnea evaluation and testing. And the fourth one will be on chronic management of sleep apnea, not just the diagnosis, but beyond that, having troubleshooting issues and so on. How do you manage that? And that is really in recognition of the fact that there are not enough sleep physicians around. So it's just kind of giving everyone a baseline of how to handle this before referring or needing a referral to a specialist. But that being said, I'm always here to help. If you all need a curbside, I know some people frown upon curbsides, but I just feel like if life has a phone a friend option, then medicine needs to have a phone a friend option as well. And so, feel free to reach out whenever you can. And beyond that as well, the reason why I'm actually also pushing this is I've created a virtual sleep and pulmonary practice. A lot of my patients are seen online. It's been huge with COVID happening as well at the same time. But beyond that as well, I think, with patients having multiple specialists to see beyond just their primary care doctors, it's hard to fit someone's schedule and life and also have their medical needs addressed. So telemedicine and the virtual practice that I founded has been helpful for patients. We also do home sleep testing. So we ship out home sleep studies to patients, and then we get that back and interpret them. We also, because we're a virtual practice, we are able to perform home sleep tests via iPhones as well. We work with the first FDA-approved iPhone sleep test that can be done and diagnose sleep apnea. We also have a prescription-based CBTI, or cognitive behavioral therapy for insomnia, which is prescribed as well, e-prescribed. And so patients can do that at home. So we have a whole suite of treatment options for patients now in the 21st century. Finally, I think we have healthcare that's caught up with the 21st century. And so that's where I think we are. We also manage CPAP as well in patients, so to ensure that they actually get the help they need. And we don't just subcontract that out to DME companies to handle. So we try to do everything just so that I think patients find a true partner in sleep care, and hopefully y'all will too. My name is Avi Bhar, and I'm going to start sharing my screen here with y'all and get started. I think there's quite a few of y'all here already. All right. Can y'all see my screen?
Yes.
All right. Let's see. I'll have to. There's a few more folks that have just walked in. All right. So like I discussed as well, we'll talk about today Sleep Medicine 101.
Yeah, wait, it looks like there are a few people in the waiting room. Can you just admit it out?
Yeah, I don't see anyone else that I can invite in.
Okay, that's fine. Go ahead.
Yeah. All right. So usual, I have to disclaimers and so on. I was actually inspired by the American Association of Sleep Medicine. They have a similar course or a course that's targeting towards nurse practitioners, because I find that nurse practitioners are at this time now being produced in large numbers, and y'all coming out graduated and being thrown into the deep end. So I really wanted us to kind of step up and actually provide a good basis for understanding how to handle patients and how to assess sleep issues. No conflict of interest, except the fact that I founded the practice, and the practice is the one that's sponsoring this. This is accredited for one contact hour by the American Association of Nurse Practitioners. And so we will then send out a post-test evaluation. And once you complete that, whoever wishes to get the 1 hour credits through the AANP can complete that survey, and we will go ahead and get you those points. There'll be 2 surveys sent out. One is an evaluation for the activity itself, which I hope everyone will fill out. And the second one would be the actual test itself. All right, so let's start with sleep basics. What I want to talk about is what basic or normal sleep is like, what regulates sleep, and then we'll kind of dive into the history taking and how to get the best out of your patients. And I'll share some anecdotes as well to kind of help you along the way. At the end of this, we will have a Q&A session. So if there's any pertinent questions, just save it till then, and we will address that. So why is sleep important? We've looked at sleep as really a passive process, but in the last few years, or at least few decades, we found that sleep actually impacts our health tremendously, whether you have atrial fibrillation or difficult to control heart disease, frequent exacerbations of your heart failure, COPD, asthma control. If you're looking at even things like diabetes control, blood pressure control, we're looking at mood issues, patients who have problems in terms of feeling depressed, for example. These are issues that we frequently will come across in our patients, but we tend to, because we don't think of sleep immediately, we tend to medicalize it and treat them with medications immediately, targeting whatever disease processes they have. So it's important, I think, for a lot of us when we do, whether you're in the nephrology field, whether you're in the cardiac field, or whether you're in the pulmonary field, is to always think about not only the 16 hours that the patient's awake and can tell you some of their problems, but also look and see how it's affecting their overall health, and see what the sleep in the 8 hours that we don't normally tend to inquire about affects them. Performance, meaning things like whether you're an athlete or whether you're a physician or a nurse practitioner, or whether you run a nuclear facility. Performance on the job is extremely important, and we're finding as well, we have these testing called psychomotor vigilance testing, which you kind of see how quick and adapt you are. We're finding patients who don't get enough sleep have such a decrease in their performance. And we're talking beyond that, even as a safety issue, patients who have inadequate sleep kind of act drunk in terms of their ability to kind of perform certain functions. So, driving with insufficient sleep or poor quality sleep is nearly as bad as driving drunk. And so that's why from a safety perspective is important. Quality of life, and this really, I've labeled it number 4 here, but in actual fact, patients don't really care about, is my diabetes better? They want to know whether they're feeling better, whether they're doing better. And I think when it comes to treating their sleep, and that's why it's been really gratifying in sleep medicine, is when you do get to the crux of the sleep issue, the patients can give you feedback immediately. I feel much better. I feel this is great. I mean, how many times do you have a blood pressure medication having an effect that way for a patient? So I think from quality of life, it's always important, whether you're dealing with any sort of field in medicine, is to always tie the patient back to, hey, this is going to help you feel this way. This is going to do this for you. And that drives their sort of compliance or adherence that we always struggle with, is because they don't really see the connection between what you're saying and how they're feeling. And it's kind of always to drive that. So that's why I always talk to patients about how they feel and how the sleep affects them. We'll go through sleep stages. Now, I found this initially. I was trying to struggle whether we actually needed. I wanted to put up the slide, but my sister sent me this her reading from her iPhone, iWatch, and she was like, "Oh, I've got certain amounts of light sleep and certain amounts of deep sleep. My deep sleep looks very little, and my light sleep looks like a lot, and I'm worried and so on." And so what light sleep basically is stage N1 and N2, and these generally are transition sleep phases. N1 and N2 make up about 50 to 55% of our overall sleep, while the deeper sleep phase, or N3 or slow wave sleep, makes up about 20% or so, and then you have REM at about 20 to 25%. But there's also a lot of night-to-night variability. So you might come across this issue where someone wants to show you something. It says, well, my deep sleep is this, or my light sleep is this. This kind of gives you a breakdown, but understand full well that it's not so much a one-night sort of measurement, but it's a trend. And so you want to see what the trend is like, because there's a lot of night-to-night variability in sleep. And this is what I just kind of went through as well, kind of the percentage breakdown, so you basically understand what REM sleep looks like. And REM sleep, oddly enough, looks a lot like wakefulness, the eye movements, the activity of the brain. And it's also one of those that I think for a lot of us, it's you think of it as a deep sleep, but in the actual fact, it's fascinating that it's one of the most active phases of sleep. It's also the phase that your heart rate variability goes up and down and all over the place. So it's a very we don't really know. And just kind of add another factoid to that is that patients who have depression, the medication effect of antidepressants is actually suppress REM sleep. And so that seems to help patients. And so that's why it goes along with sleep restriction as a way to treat some depression symptoms as well. But again, I think we'll fully discover this as the years to come by about what each stage represents. This is a hypnogram and the reason why I want to show you this is if you're looking at over here, you'll see that at around midnight is when the patient finally falls asleep. And when they do go to sleep, there's wakefulness, there's REM sleep here, which is the black bars over here, and you get stage N1 and N2 and N3 sleep. But it's a cycling of the sleep. This is one cycle, usually about 90 minutes to 100, depending, because you see this patient woke up here, so their sleep was disrupted. But most of these cycles, and most of the time, you'll need about 90 minutes, you'll need about 4 to 5 of these cycles to actually feel refreshed. And it's important to have consolidated sleep. So that's why having 3 hours here and 2 hours there doesn't really actually translate into the same sort of restorative sleep that patients are looking for, that all of us are looking for. And so you'll see as well in patients who are hospitalized will end up getting a lot of delirium, is because they end up having a lot of small blocks of sleep throughout, as opposed to a consolidated sleep where you start seeing initially a lot of non-REM sleep predominant. And then as the night progresses, you'll find a balance of non-REM versus REM sleep as well. So you'll see that throughout. And so that's the whole idea of actually showing you this slide, is kind of bring the idea that you need about 4, and you'll have patients who swear by, oh, doc, I don't need more than 4 or 5 hours of sleep. And, I'm a rock star. And I was like, unless you live on cocaine, that's going to be really difficult. So the idea behind this is actually show a lot of patients actually feel like they don't need as much sleep, but you will realize that they adapt and they find ways to cope with it, meaning that they use a lot of caffeine, a lot of energy drinks. They try to take naps, they feel sleepy and they have to get up and walk around and so on. So people adapt, and people also tend to forget what good sleep was like. So as they live with poor sleep, they will claim that, oh, I'm doing fine for most of the time, until you kind of delve into the medical history and really delve into their sleep history as well. And so how we measure sleep is using something called a polysomnogram. And so that's a sleep study that's done in a lab itself. So the gentleman down here with this device on his hand, on his wrist, that's a home sleep device. A home sleep device doesn't really measure sleep. It measures respiratory events during the time you switch on and you switch off the device. And so it doesn't really correlate or give you an accurate measurement of your sleep, but it's a good enough way. And we'll delve into that when we go into the sleep apnea evaluation and testing part of our series. These polysomnography is something that most patients don't like. They have difficulty understanding how they can sleep, but trust me, sleep is one of those things that will come and get you at some point. So patients do fall asleep. This is what someone looks like, and that's why there's a lot of hesitation to going through an in-lab study, but it gives us a whole lot more information. Now, we don't need all the information on everyone, and we generally just need, if it's sleep apnea, then a home sleep test should be good enough, unless of course an underlying disease. And again, we'll go through that in the other webinar series. So it measures oxygen, it measures your EEG, it measures your EMG as well, which is your muscle sensors to see whether you have any clenching and so on of your jaw. Chin leads and EKG lead as well. So we've talked about, sleep and what basic sleep looks like. The regulation of sleep is also important. There are two main factors that are within our control. One is homeostasis, which is the drive to sleep. Homeostasis means basically the longer you are awake. This is not the definition of homeostasis, but the drive to sleep. The longer you're awake, the more likely you are to fall asleep. And so when you hit about 16 to 18 hours, that's your threshold that you really can't stay awake any longer, unless of course you have other things that are intervening. Circadian cycle is basically day and night wake cycle. Those two things have to get aligned or be aligned for us to get good sleep. A lot of times, though, there's an accumulation of sleep drive, there is a scheduling issue or a circadian rhythm issue. And we'll find a lot of that as well. Actually, I've come across a lot of patients, especially with the home lockdown, and patients that have been working from home. They don't get out as much. So there's not enough light exposure. So they don't actually get into the circadian rhythm really well. They also sometimes have the ability to take a nap at lunchtime at home. So that takes away some of their sleep drive. And so there's various reasons why looking at these two factors and making sure that your sleep drive coincides with the circadian rhythm or your cycle is extremely important. And so that's why I think nowadays with the pandemic and so on, it's been fascinating for me to kind of see how patients have been struggling for sleep, mainly because of sleep scheduling issues, which they used to keep to at a time when they knew they had to get into car and drive and so on to get to work. But now they get to work from home, they get to sleep in, they get to take a nap, they don't walk around or get out as much as well. So that disrupts their sort of entrainment to the environment to make sure that the daytime they're awake and nighttime they're ready for sleep. The ultradian mechanism is basically the balance between REM and non-REM. You'll find that every day, every night, your REM and non-REM amounts are never equal. But what you'll find is patients who have lack of sleep and then get catch-up sleep, the night that they get catch-up sleep, they actually have very limited REM sleep. Most of the catch-up night sleep is non-REM. So whenever I have patients that tell me, I'm busting my ass till about Friday, and then I take a nap on Friday night, and I feel great on Saturday, and I feel good again, I get recharged. But it takes more than a day to actually get back to regular sleep or your non-REM REM balance. And that's important as well. And this is kind of giving you a pictorial understanding of what we discussed, which is the sleep drive accumulates. So you can see that the tendency for you to fall asleep pushes down on you for you to getting into bed. As the day progresses and you're exposed to light that entrains you, there's always a dip in the afternoon. But as you then get to a certain time when you're about 16 to 18 hours into it, that's when your tendency, then everything acts against you in a good way to fall asleep. And that's why the homeostatic drive and the circadian rhythm allows you to actually fall asleep. Now, how do you assess sleep? Now, what is normal sleep? What is quality of sleep? What are the complaints some patients give you? What are some complaints that the bed partner or the spouse may give you as well? And what's observed? Normal sleep in most patients, in the recommended hours is between 7 to 8 hours. I personally know mine to be about 7 hours, and the reason and how you figure yours out is, unless of course you're one of my patients who says they can live off 5 hours and swear by it. But if you're like the rest of us, poor folk that actually need 7 to 8 hours of sleep, what you want to do is ensure that you have regular sleep the days before that. Then go to sleep when you normally do, but don't set an alarm. And do this for 2 or 3 days if you can afford to do that, and then see what time you wake up and how you feel. I always thought mine was about 6 hours, 6.5 hours, and 6 hours and 45 minutes was that with my sweet spot. But I noticed that when I did this, the 7.5 hour mark was where I kept landing, and I felt way better. And so if you're honest with yourself and you actually are able to do this, you can actually kind of tell what's your optimal sleep time. Quality of sleep. Environment is important. You want it to be dark, you want it to be cool, you want it to be quiet. Most of the time, the sleep environment itself is not going to be something that you as a provider need to address, because most patients have already addressed this on their own. It's usually a lot of it is common sense. Sleep disorders may affect your quality of sleep. So if they have underlying sleep apnea, insomnia, restless legs, other sleep disorders, that will affect their quality of sleep. Snoring as well may affect their quality of sleep. Circadian factors. So if you're on shift work, if there is a change in your daylight savings time, for example, is there a change in seasons as well? These factors then have a larger role to play. Again, it depends on the individual. Some people won't even notice it, and some people struggle with it. So making sure the circadian factors as well is important. Now, circadian factors is interesting, because you'll find that some patients will want to sleep at certain times because it's socially acceptable. And so that's when you get into sleep history and find out why. But if your environment is correct and you've addressed the sleep disorders and your circadian factors are okay, then you should be able to fall asleep. Now, sleep-related complaints. Even though the symptoms during wake periods is listed second, this is what, if you're not within the sleep field, most of my patients come in and I know they have a sleep disorder, so I can kind of dive in directly and hone in on that history. Most of your history would be, or where you get clues from, would be from symptoms during wake periods, whether they have mood disorders, whether they're going up on their antidepressants, or they're increasing doses of that, whether they're on benzodiazepines, whether they complain that they're more irritable, whether they complain of job performance issues, whether they complain that their cardiologist wants them to go for further testing because their arrhythmia is out of control, whether they have more fluid accumulation in their legs. So these are all symptoms of maybe heart disease or stress in the heart, blood pressure issues, and so on, which you then need to pick up on as a potential clue and then start asking more targeted sleep questions. So y'all, a lot of y'all, especially if y'all are not directly in the sleep field, is symptoms during wake periods, and then tying that back to, oh, okay, that's a clue for me to start asking few more sleep related questions. Symptoms during sleep, we'll talk about in a little bit as well, whether they're snoring, whether they wake up a lot. And it's always interesting, fascinating for me, because I will have patients who, when I ask them, I say, do you snore? And their first response is a pause, and they're like, no. And then, but someone has mentioned that I do snore, but I'm not sure that I snore. And so people are defensive. So if you do ask that question, do you snore? And they say no, I want you not to give up at that point and actually ask them, has anyone else accused them of snoring? And then they will also mitigate that by saying, well, it's only when I'm really tired, or I'm not a loud snorer. I'm more of a purrer or a heavy breather. But all of this adds to your history on whether there's any difficulty or a little bit more of a struggle to breathe. So symptoms during sleep, which we'll go into a little bit more as well. Sleep-related observations. Now, I love bed partner observations because that makes my life a lot easier. As soon as they can tell me that their bed partner, the spouse, has mentioned to them that they've either stopped breathing or struggled to breathe, I can put down my paper and pen and just go, okay, you have sleep apnea. And, this session is over. Not literally, but in terms of knowing what they have, that's an easy way to get that. Again, that's nicely wrapped up for you, but a lot of times patients won't give you that. So struggling with breathing, I will also mimic how sleep apnea sounds like. So I'm going to do this, but please don't laugh at me. It is just basically a lot of then. And so that's that apneic episode there. It's when they have that cessation or the reduction in the snoring volume, and then they have this gasping or that breakthrough when they actually have a micro arousal or arousal that allows them to wake up and breathe. And so this happens multiple times at night. So if the bed partner can say they have witness apneas, or they struggle to breathe, or they restless sleep, and so on, these are important points as well to kind of allude to the patient that that's why they need further testing or evaluation, is because of all of the symptoms. Because again, just the same way in the medical field, we have been a lot of times medicalizing things. So in terms of like heart disease, you treat medication, you give this and give that. Patients also take that seriously because, again, the heart is important and we want to make sure we address that. When we think of sleep, we also a lot of patients think of it as a passive process. Oh, I don't want another diagnosis. I've already got enough diagnosis, doc. I just don't need another one on my plate. So that's why it's important for us to tie in even what their partner observes and explain to them what that means. An observed apnea, meaning they actually stop breathing literally, and tie that in with their quality of life and how they feel. And that, at least that way, that opens up a avenue to talk about why sleep is important. Observations of the individual, and this will go into a little bit more as well, some of the symptoms they describe, which is sometimes scary for them, but when you actually allow them to speak and they are able to share that, they realize how normal it is, and you kind of need to validate that. So before we kind of jump into the history, let's talk about what this all means. If you're not getting enough sleep, if you're not getting enough hours, and just because you have 7 hours of sleep or 7.5 hours of sleep, if you have underlying insomnia or restless legs or even sleep apnea or REM behavior disorders, your sleep is disrupted. So your quality of sleep truly isn't, or your actual sleep isn't 7.5 or 8 hours. It's a lot less than that. So that's why when you ask these patients, so even though they sleep at 10 and wake up at 6, they will tell you that they feel like they've only slept a few hours, or they feel like they could use another nap right after waking up. So what does acute sleep loss look like, or what does it mean for a lot of people? Slow response times, taking longer time to respond to a question, for example. In the healthcare field, it's extremely important. Reduce attention. We find a lot of patients, I find as well, and I think this is something we all need to have I guess, be more aware of, is attention deficit disorders. I think there's been a huge amount of attention deficit disorders. You see a lot of people on stimulants now, but no one really asks them their sleep history. Now, a lot of attention deficit disorder patients will also have some sleep symptoms, which is part of their diagnostic criteria itself. But if you don't, or if you ignore the sleep issues that may be occurring at the same time and not addressing that directly, you'll find that a lot of their medication needs increase, and you're always chasing that. So that's why reduced attention or ADHD is something, for me, is a red flag. Whenever I see that, whenever I see stimulants on, I'm like, oh, okay, they have an issue that we need to address and figure out if sleep really is causing some of the worsening of ADHD. Mood symptoms as well, mental health. That's also gotten a lot of press, but I think more importantly, we used to always struggle whether insomnia was primary versus secondary, or whether which cart came first, the horse or the cart. But at this time, we realized that when you have mental health issues, you are likely to have some sort of, if you do have any sleep issues, and it has a bi-directional relationship, meaning sleep issues can lead to mental health issues, and mental health issues can lead to sleep problems as well. Impaired problem solving and moral reasoning, that was an interesting study, but yeah, it does impair your moral reasoning, and it also affects your problem solving ability, so executive functioning and so on at work. Health effects. So we know now, with a lot of studies out, that increases mortality if you don't get enough sleep, leads to weight gain, and I've got a really cool little slide after this to show you that. Diabetes control, blood pressure control. I just had a telemedicine visit with a patient a few short hours ago, and he was on 5 different blood pressure meds, and he's not even 35 years old. But his issue was sleep apnea, and he's noticed now that he's checked his blood pressure now since he's been on CPAP, and he says his blood pressure has come down, and it's downtrended tremendously to the point that he's motivated to use his CPAP even more. So you'll find that the correlation is not between blood pressure control and CPAP is not only in studies, but you'll see patients as well validating some of that. And that also motivates them, is if you can get off like from 5 medications, you get 2 or 3 medications, you also deal with less side effects of these medications. Increased risk of psychiatric disorder, which we spoke about. It predicts long-term sickness and absence as well. So that's why a lot of employers are now taking sleep issues beyond just safety, whether you work as a pilot or whether I'm sure at some point in healthcare, you will find a lot more of at least some focus on sleep to ensure that their population of workers, whether you're LPN or whether you're an MD or NP, that sleep is taken as a crucial part of it, because it does affect your decision-making ability. Impaired neurocognitive function, we've seen as well the correlation between a lot of patients now with Alzheimer's and so on. And there's a lot of studies now underway and have also proven that there's an association between insufficient sleep or poor sleep with the development of Alzheimer's. So like I mentioned earlier, this study kind of shows you, sorry for if it's blurred a little bit, but this is a timeline of when the study was started in the 80s and up to 2002. And this is, and this is the weight gain. So If you look at patients here who've had between 7 to 8 hours of sleep, they have gained weight, but it's markedly less than patients who've had 9 to 6 hours of sleep and even 5 hours of sleep here. So you can see that these patients who claim that they only get away with 5 hours of sleep, it'll be interesting if you met them 10 years later and see whether they've gained that much of weight. So it's important for us as well. We do know that the stress response of your body when you get insufficient sleep is very different. How it treats nutrients is also very different. Even your ability to stop snacking as well is important in terms of how much sleep you have and whether you're able to do that. Because I know when I pulled an all-nighter in college and so on, the next day all you want to do is sit down and veg out and not really be active. And when you explain this to patients, again, it highlights that connection between the sleep and how they feel the next day. We know the mortality risk is there, especially if you have less than 6 hours of sleep or more than 9 hours of sleep consistently. This is not a 1 to 2 night thing. This is not a few weeks to a month thing. Some people will get anxious about, oh my God, my mortality is going to increase if I don't sleep well the next few days. I think you should always give sleep some at least focus and think about it when you're not feeling well. But in terms of freaking out about it and being anxious about it, I think that might be these are long-term studies where we've seen that. Now, we'll talk about a little bit is now the sleep history and how to get. Now I've peppered a lot of the talk with some anecdotes and so on, and we'll kind of bring this all home and describe kind of how to get the best of your sleep history. Questions to ask and exam findings. And again, I might be a little biased, but in sleep medicine, the physical exam itself is not as pertinent. I will look at a patient's airway in telemedicine. I can examine an airway pretty quickly with their phone in front of them. If you have any issues in terms of restless legs is a problem, then you may want to do a physical exam, or they have REM behavior disorders. These are all other neurocognitive disorders related to sleep. In those patients, yeah, physical exam will be pertinent. Review your systems. Now, a lot of the times telling them to switch off their lights and making sure it's cool and quiet is something most patients have already done. But where they forget to look at is their sleep scheduling. There's a lot of social pressures to sleep at a certain time, whether it's their spouse falling asleep at a certain time, or everyone in the house goes to sleep at a certain time, or that's a time I always thought that I should go to sleep because I want to get my 8 hours of sleep. But in actual fact, you should actually schedule your sleep time when you're feeling sleepy. What you should really do is schedule your wake time. And we'll go into that when we talk about the next webinar on insomnia and how to deal with that. So the scheduling is important, figuring out what their weekend and weekday schedule looks like and when do they have the most amount of difficulty falling asleep. Breathing during sleep, whether it's snoring, whether the partner sees them stop breathing. Now, I've had patients who describe vivid dreams about choking in their sleep, drowning in their sleep, unable to breathe in their sleep, which is terrifying. But when you explain to them why they're feeling that way, it's because they actually are having an apneic episode. It widens their eyes. Morning headaches. I've had a lot of patients who are on Topamax and a lot of other headaches or migraine medications, but sleep apnea and it's I guess it's more severe cousin, obesity, hypoventilation, can cause headaches to occur. The difference in the nature of these headaches are the headaches get better as the day progresses. So it should be worse as soon as they wake up. And patients don't normally have this every day. It's again from day to day. Movement issues. Abnormal leg sensations, restless legs, feeling an unease. We'll go through this on the 5th webinar on restless legs and talk about how patients describe it, whether it's difficult for them to fall asleep with it. Then there's a subset of restless legs, which is leg movements or leg twitches, which look like restless legs, but only occur when they're asleep. And that's called PLMD, periodic limb movement disorder. And I actually have that at times, and I know what triggers it. Stress triggers it. Alcohol triggers it. And so for me, those are, and it will cause me to run in my sleep. And so I've had to change bed sheets because I wore out the bed sheets from my PLMD. So it is something that does cause arousals, and I will wake up the next morning feeling like I had poor sleep. And so, leg movements, kicking, jerking, and this is where the spouse comes in, because the spouse can really attest to whether they're twitching in their sleep or seem like they're running in their sleep. Parasomnias, odd things that you do in your sleep. Acting out dreams is something you should not be doing. And so this is one of those where you may dream, but you shouldn't be punching or kicking. If you're fighting something off, you shouldn't hurt your bed partner or hurt yourself fighting that off, because I've had patients who do that, and that's something called REM behavior disorder, and that's a serious disease, and that needs to be looked at closely. So patients shouldn't be acting out their dreams. Daytime sleepiness or symptoms. Most patients won't describe daytime sleepiness. We normally get them to fill out an Epworth sleepiness scale, but they will talk about fatigue, low energy. And this is how they tend to get shunted to different pathways or different sort of rabbit holes. As most physicians would do, you'll check a TSH level or you will check a testosterone level. And the problem with that is you might find a TSH level that's borderline or consistent with subclinical hypothyroidism, but then because of the complaints of low energy or feeling fatigued or weight gain, there's a tendency to treat that, but actually not treat the actual underlying issue which caused that fatigue or low energy. And so you get patients who have that when it comes to mental health issues. They'll complain of one thing, they get tracked as someone who's depressive, and then they get treated with antidepressants. And you have patients who have low testosterone levels or borderline low, and they start getting treated. Now, none of these treatments are without effect, because all the drugs that we prescribe all have side effects, and we have to be aware the patient bears the cost of that. And so it's important for us to make sure that before we evaluate that, we also think about sleep as an issue for their fatigue and low energy. And in actual fact, testosterone shots make sleep apnea worse. So if you have someone whose underlying issue is sleep apnea and they're complaining of low energy and low sex drive and low libido, all of these symptoms are also consistent with sleep apnea, you end up actually worsening their sleep apnea. So the daytime symptoms are important: fatigue, different words that patients use, symptoms of hallucination when they're falling asleep, muscle weakness, and so on. Hallucinations are hypnagogic and hypnopompic hallucinations. As they're falling asleep or as they're waking up, they feel they hear something or see something, and so on. That can be part of another sleep disorder, such as narcolepsy. Same with cataplexy as well, where someone startles them or screams at them, or they get upset and they are weak in the knees and they buckle, or they feel like their jaws slack off and they can't control their muscles. And sleep paralysis is another scary one. I've had that before as well, when you feel like you're waking up, but your mind's awake and you're aware around you, but you can't move your body. And so some patients have that. Mine is stress related and also insufficient sleep related as well. So when I've pulled a few all-nighters, I might have the third night when I try to get some sleep is when I have it. Some patients will not mention that to anyone because they just think it's crazy. And so when I bring that up as a history, it's interesting to see their eyes light up and they don't think that crazy. Sleeping medication use is an important clue. Most patients, if, for example, they've been treated with trazodone or mirtazapine to help them fall asleep, they won't even mention to me that they've had sleep issues. They will just say that, oh yeah, I'm fine and so on. But in actual fact, it's an underlying issue. Current treatment, whether they're using any sort of, whether they have a sleep number bed is also interesting to ask, because patients will go into that in scientific detail about how they dealt with their sleep and their snoring and what position and the sleep number bed they use and what sort of mattress and what sort of pillow. And patients want me to tell them which pillow I recommend. I say, pillow isn't really the problem. It's sleep apnea is the problem, but hey. And so current treatments by patients is important because it gives you an idea of how long they've been struggling with all of this. Constitutional symptoms, hot flashes, important because women tend to get a lot more in terms of, insomnia tends to occur when they have hot flashes and so on, but when they are menopausal or perimenopausal. And then after menopause, they actually tend to have a much higher risk of sleep apnea and catch up with men overall. So constitutional symptoms to figure out whether they are menopausal. Surgical history of whether they've had a hysterectomy as well is important. Whether they've had their ovaries removed is also important because the lack of estrogen increases their risk. Respiratory history, I've dealt with a lot of patients, and this is basically the reason I went into sleep medicine, is because a lot of my patients had pulmonary issues, and their pulmonary issues or respiratory issues worsened at night. And so understanding what was triggering it, and there's a lot of studies out now that your asthma control actually is worsened if your sleep apnea is not triggered or not addressed appropriately. So it's interesting to see how that all overlaps. Sinus issues make sense. The more clogged up or the inability to breathe increases your risk of sleep apnea because you have an obstruction, basically. Cardiac patients, palpitation is a big issue, or arrhythmias. Just give you one stat to give you an idea. you see patients who are going through AFib, atrial fibrillation, and then they have the rapid ventricular response and they can't control that, and they go for an ablation, and then they have a failure of the ablation. A lot of these patients who fail an ablation within 12, they have 80% likelihood of having sleep apnea as an underlying cause. So just think about that as how often we're not thinking about sleep or sleep apnea or sleep issues as a trigger for atrial fibrillation. So palpitations, blood pressure control, especially if they start having resistant hypertension, a lot more than 50 to 70% of patients actually have sleep apnea that's driving their resistance. Acid reflux is also another interesting one. Patients who have this negative, or when they have an obstruction in the upper airway, they tend to breathe or suck against that, and that actually increases the negative pressure here. And what the negative pressure does is when they're laying down flat, it actually draws their gastric juices and causes their refluxing or aspiration to occur. So you'll find patients who have bad acid reflux will also tend to have it at night, and the trigger could be sleep apnea. Muscle and so on, the back pain, hypotonia, these are for other neurological problems that manifest with sleep issues. Back pain as well, if you have restless legs, to make sure the back pain is not an issue. But pain as well, in terms of their perception of pain, gets a lot worse the poorer the sleep is. So if you have patients who are asking for more and more medications, pain meds and so on, apart from obviously doing the due diligence to make sure they're not addicted to it or dependent on the drugs itself, is to see that you can mitigate some of the risk of pain perception issues by giving them, ensuring that they actually have better quality sleep, whether it's sleep apnea, whether it's insomnia and so on, is to address that. Patients who have stroke, and we know strokes are an increased risk in patients who have untreated sleep apnea, headache patients, and that's why headaches are also important, because you can explain to patients, hey, listen, this is not just another diagnosis. If you get treated, if you do get diagnosed with sleep apnea, for example, and we do treat you, there's a chance that a lot of these medications, a lot of the symptoms that you had, that you're on like 5, 6, 8, I don't know, 20 medications. Yes, I just saw 20 yesterday on a patient of mine. These medications can be reduced. I'm not suggesting that they all can be taken off, but you'll find that the doses come down. So patients who have been misdiagnosed and mistreated with different medications, you can actually get a mitigating effect if you get the sleep issues treated. Scheduling of sleep. What time do they wake up? What time do they fall asleep? Why do they go to sleep at that time? Why do they wake up at that time? What sets them up? What wakes them up? Is it they wake up at 3 or 4 in the morning to use the restroom? Is it because they have a dog to feed? Or is this, are they a caregiver at home and they have to wake up in the middle of the night? How long does it take them to fall asleep? Sleep latency. If the longer it takes you to fall asleep, more than 20 minutes, that's when you need to start figuring out if that's something to address. If they're going to bed before they're ready for sleep, that's also another question, because if they have to go to sleep, is, well, my wife's going to sleep, or my husband works a night shift and he comes back and I'm exhausted, I really want to sleep earlier. So you have to figure out when your own personal sleep time is based on how sleepy you are. Night awakenings. Waking up once, twice a night is well within normal limits in most patients. The ability to fall back asleep is what's important. So if you're able to turn around and go back to sleep again, that's fine. If you wake up 2 to 3 times and you're staying awake for 30, 40 minutes and you're just staring at the ceiling, that's when you have an issue and needs to be addressed. Nocturia, peeing at night. If I can make just one plea to everyone, is when you hear patients are having issues with waking up to pee at night, they shouldn't, unless they have BPH issues, because we have an internal mechanism called the ADH system, the anti-diuretic system, which will regulate so you're not waking up all through the night to pee. Now, what affects and causes you to pee at night is a lot of times sleep apnea. When you have, like I described, the negative thoracic pressure, because you're choking here and you're breathing hard against a closed airway, what that does is causes a lot of intrathoracic pressure shifts. So your whole chest wall internally shifts, and that affects how the chest or the lungs compress against your heart as well. And that actually, once your heart feels like this is an issue with congestion and so on, it's going to release an atrial natriuretic peptide. And that is a diuretic that causes a patient to pee. I always note this down, because when I want to speak to a patient after, when they get treated with sleep apnea, they're feeling better. I'm like, how often are you peeing now? I was like, well, I don't even wake up to pee anymore. I didn't even notice that. So instead of sending your patients to a urologist to get evaluated, is to actually ask them if their stream is good. If their stream is good, then it's not likely BPH. It's probably a diuretic that's naturally occurring due to undiagnosed sleep apnea. Activities at night, patients will say they wake up and they do certain things because try to get them back to sleep again. If they have to feed someone or they have to change someone and so on, and that's something important to know what they have to do at night or what's a role they have at night. I have patients who have BPH issues, so instead of them switching on the light, the solution was to get a night light in the restroom itself. So that avoids them having to switch on a big light, which is a trigger for them to awake as well. Naps during the day is another way to figure out if someone has a sleep issue, especially if you start taking naps and they well, I feel like it because I can, but it's also to figure out if they're napping as a way to what's it called again, compensate for a lack of sleep at night. Work and daytime schedule is something I go into as well if I have a patient with shift work disorder. But I'm going to pause here as well. I want to address the fact that I don't ask all these questions on every one of my patients. It's always trying to assess what their issue is and then deep diving into that specific field. So, do I ask them every night, do they wake up to caregive someone? No, I don't. But if I ask them how many times they wake up and they say 5 or 6 times, then I want to know why they're waking up that many times. How many times of that 5-time awakening is to pee? How many of that time is for no apparent reason? Are you able to fall asleep again? Do you have pets that sleep in the bed with you? And all of these things to kind of figure out and trust me, you'll never win that battle with the pet sleeping in the bed. I've given up. But all you can do is just tell them, that's probably what's causing it. Medical and surgical history, whether they've had tonsillectomies is an important thing, whether they've had hysterectomies as well, whether they've had UPPP, where they've had the uvula removed and they have parts of the palate shaved off as well. Now, a lot of patients had this back in the 2000s when the data wasn't really out against it, but now we know for sure those kind of surgeries actually didn't really benefit patients. And what we find was there's a relapse that occurred a few years down the road. So trying to figure out whether they have any other surgeries in the past. Sleep studies are important, especially if it's positive. If they're negative, I take it with a pinch of salt because there's so much night-to-night variability. And if they're back to see a sleep physician or they have sleep issues again, I'm probably going to get them retested. Just the same way, just because an echo was negative 5 years ago and they come in now with cardiac symptoms again, doesn't mean that you don't do the echo, because that things can change as you age as well. Reviewing other medical diagnoses is extremely important. When I start assessing a patient, the first 2 things I personally look at is a problem list and a medication list. Medication list first and then the problem list, because medications don't lie. When you prescribe something, physicians have heard a complaint and prescribed something. Problem list may not be as well or populated just because not everyone is diligent about ordering a hypertensive medication and going to the problem list and adding hypertension on. So I find that the medication list is extremely important to a lot of my patients. And that's been one of the benefits of telemedicine. A lot of my patients don't have the excuses, oh, I forgot, because they literally are sitting at home. They'll walk over to their medicine cabinets and they'll show me what they're taking. So that's been an easy fix for a lot of my trying to get an up-to-date medication list for patients. And speaking of medications, whether you're using narcotics, we know about that. Antidepressants. Now, antidepressants may have different effects on different people. For some patients, it is an effect that causes them to feel more awake. For some patients, it causes them to feel more sleepy. So to find out how they feel after taking these medications is important. Some of them will wake up and take an antidepressant and go back to sleep again. And you're like, well, if that's the case, then you may want to speak to your psychiatrist or whoever's prescribing it. I would suggest shifting it to the nighttime, since it seems to be causing you to feel fatigued or sleepy. Beta blockers often cause fatigue as an effect. Taking a beta agonist, like if they take a nebulizer treatment of albuterol at night, may cause some jitteriness throughout the day. So all these medications is something to kind of take note of, because it helps you kind of figure out in the history what can be reduced, or when you're speaking to them, what dose can be reduced to see the effect. And then also figuring out the timeline of their complaints with when that medication was started. So it's important, because just because a medication may cause an effect, it doesn't mean that it does cause that effect. So if you see a medication that may be causing some of the symptoms, is to ask the patient the timeline of the symptoms and when they actually started the medication. History, personal history, occupation, especially for me, for truck drivers, patients whose sleep affects safety issues, is something that we'll ask for. Occupation history is also important for patients who work shift work. The living situation, if they are caregivers to others, again, this is if you have more time to go into, you can. Patients who are struggling with insomnia, especially if they have prior drug use or alcohol abuse, you'll find as well so many people in our community self-medicate with alcohol to get to sleep without treating the underlying issues as well. So that's also another trigger. If you see alcohol on a nightly dailies, to ask them why and how much they need to drink. Caffeine use is important, especially as a way to compensate for sleepiness, whether it's caffeine, whether it's stimulant drinks or energy drinks and so on, which is growing, not growing in popularity, it's super popular. So find out about that, because patients will tell you how much they're dependent on that to keep going. Exercise is important, but again, just like medications, it has a variable effect on patients. For some patients, it is a great way to get ready or prepare them psychologically for bed. They'll have a shower, they feel great, they'll rest for about an hour before they go to bed. Some people can do that. Some people, any exercise within 3 to 4 hours is bad news, because that triggers their sympathetic system and they can't go to sleep. So I wouldn't say no to exercise. It depends on how the exercise affects their sleep. Family history, again, do I go into a long family history? I really don't. But if a patient comes in with cardiac history or palpitations or cardiac, and I'm going to pause here a little bit and just kind of digress. Cardiac patients don't normally have a lot of symptoms of sleepiness. Because of the hyperadrenergic state that they're in, sleepiness is not a common complaint, but it's their medical problems that will speak volumes about potential sleep issues. So in patients such as that, what you want to bring about is the effect that poor sleep may have on their heart health and their mortality. But beyond that as well is to ask history of anyone with sudden cardiac death in their family, or anyone else with sleep apnea or breathing issues or sleep issues. And sudden cardiac death isn't important, because patients, VTAC and so on, 30, 40 years ago was something patients died off at home and were brought into hospital after that. So it's important for us to get those kind of histories and symptoms as well. Was your mom or your dad always? Again, do I ask these questions all the time? No, I don't, unless, of course, for example, if I feel like I need to increase my ability to kind of communicate with the patient, make sure that they know how important this is. Because if they see history already being in terms of historical data of a family member dying of a sleep issue, that motivates them and we want to make sure that they are addressing this with a lot more vigor. Neurological diseases, things like Parkinson's disease, things like multi-system atrophy, things like Lewy body dementias. These are all neurological diseases that also go hand in hand with a lot of sleep issues as well. So this is a trustworthy Epworth sleepiness scale. Anything 10 and above or above 10 is considered pathological, but just because your patient does not have a score of 10 and above does not mean that they're not sleepy. For one is that the motivation, some patients, for example, truck drivers and so on, and patients who are working on work that is essential for them to report how awake they are so that jobs don't get taken away from them, may not be as honest. Some people who don't want to go through a sleep evaluation may try to downplay the symptoms that they have. So the motivation behind how they answer this question sometimes is called into question. But beyond that, there's also difference in whether these scales are administered by a healthcare professional or whether it's self-scored. So meaning the patient reads this and fills up the answers themselves. They're scored from a score of 0 to 3. So the 24 is the max amount. And so patients who are positive above 10, I normally will look at that and follow that up as they age. But in patients who don't have that, I still want to get back into the clinical history to make sure. So just because their ESS or the Epworth sleepiness score is not pathological does not mean they don't have daytime sleepiness or fatigue. Stop bang score. And this stop bang score has been really useful in certain patient populations, especially in pre-op testing and evaluation in these patients. You'll find hospitals now are very diligent about putting these bands saying high OSA risk of different colors. And the only concern I have about that is a lot of times if you ask the hospital system, what do they do about the bands after that? Is there a pathway for them to get tested? There really isn't. And so if you want an easy QI project is to figure out what happens to these patients. They get tagged for high risk of sleep apnea and what happens after that to them. How many of them actually get sleep testing? Because when you get discharged, you have that thick of paperwork to go through, and sleep testing may be right at the bottom there as well. So it's important for us. So I digress from speaking about our colleagues in anesthesiology. It's a decent tool to use, and I think it's used well in certain patient population. You talk about snoring, S. T is for things like tiredness, fatigue. O is for observed apnea, stopping breathing in these patients. P for pressure or hypertension. B for BMI, above 35. Now, again, that is also something I take with a pinch of salt, because anyone who has a BMI above 30 and have sleep symptoms, I take them seriously nonetheless. Also, in patients who are of Asian descent as well, a BMI of any BMI is a risk factor.
Dr.
Cardiac
Doctor,
patients.
we have another 5 minutes.
Okay, cardiac patients is also another a patient population that we look at as well, and who may not have the original BMI that we normally used to. But anything 3 and above is considered a moderate risk and above. Physical exam, we'll do the BMI, which patient comes in, it's pretty easily done. I'll look at the upper airway, which we'll talk about as well. The cardiopulmonary exam, again, is of limited value, and again, symptom-specific exams if you're dealing with neurological diseases. This is the Malampati score. I generally use the modified Malampati score, which is, it's no one sleeps with their tongue going, ah. Most of the people sleep with their tongue in their mouth. I'm pretty sure about that. So you would want to, what I normally will do is ask patients to open their mouth, and this is done to tele. So if I can see by tele, you can see them in person pretty easily. I just ask them to open their mouth and keep their tongue relaxed at the base of their mouth. So I want to see that, and I want to be close enough where there's enough lining to see the back of their throat. So you'll see the classes here. Class 3 and class 4 heralds are high risk. But again, this is taken when someone is sitting upright in front of you. You always have to consider the fact that when someone lays down and their tongue falls back, how much narrower that airway is. Scalloping of the tongue is another one that I use frequently. It just means that the tongue is too big for their lower jaw. And if it's too big for the lower jaw, it's trying to push up against the back of your teeth, causing the scalloping. Then I imagine as well what it looks like at night when they're falling asleep and the tongue flops backwards. I normally don't look at tonsil size. I will note it down in my first exam. The only time that I personally find it, especially in adult medicine, when tonsil size is important, is the CPAP pressures are high, or they start needing BiPAP, and the pressures are high in requirement, or they don't tolerate the high pressures. At that point, considering like if you have a class 3 or class 4 tonsils for a tonsillectomy, that's when I would consider that important. All right, so in summary, we spoke about what basic sleep looks like. We spoke about what regulation of sleep looks like. We spoke about what the homeostasis and the circadian rhythm, along with the REM and non-REM balance. We spoke about what the consequences of acute sleep or acute sleep loss is. Then we also discussed, or at least I blabbered on about, how to get the best history out of a patient, physical examination in these patients, but also tying in the patient's clinical symptoms, meaning how they feel during their daytime, how it affects how sleep. And that's when you have to kind of marry those 2 points, because really, if you don't get that across to them, they're not really going to take their sleep as seriously. And one thing I personally feel is the three crutches, or the three main points of good health is really mobility, good nutrition, and good sleep. So you want to make sure you get that across to a lot of your patients. I am going to pause here for a minute, and I'm going to allow y'all to ask any questions if y'all have any at this point. Vignesh, can they ask questions?
Yes, they can just unmute and ask if they have any.
Well, I'm not sure whether they have.
I have a quick question.
Sure.
And you may go over this in the next lecture about insomnia, but I have many patients that have just been on medications like Ambien for years.
Mm-hmm.
And so I guess how would you address that if they're happily on Ambien every single night, or even just like often?
So I tend to, you have to pick your battles. And so what I will do is, if they've been on it before, I don't even touch that. I don't even mention coming off that. What I want to know is figuring out what the underlying problem is that led them to get Ambien or start taking Ambien, and trying to figure out whether it's a scheduling issue, whether it's an underlying sleep apnea issue, whether it's a medication interaction issue, whether it's a pain issue. So trying to figure out what the underlying cause is, addressing that appropriately and treating that, and then kind of letting them know that, hey, listen, this should help with your sleep. Now, what you would want to do is, on days that you feel like you're doing okay, you may want to go ahead and try halving your dose if you feel comfortable doing that, or even cutting it down by 25% if they're really hesitant and you can break it down. Certain pills can't be scored that much. and they're not scored enough to go down to quarter. But if you feel like on a day that you don't need it, don't take all of it and see how you feel. And most patients, you will find it's a lot of it is, especially the Ambiens and so on, their risk of addiction is not as bad as the traditional benzodiazepines. So that's why for Ambien, I'd say, try not taking it or taking half a dose and see how you feel. I just want to convince them, or at least lay the seed of idea that, hey, you did manage good sleep for the last 2 or 3 nights when you went half the dose. So whenever you feel like it, if you don't want to take it or stop taking it, then you can do that in a few weeks. But there's always a risk of rebound insomnia. So that's why I allow them at their own pace and time. Now, there's some therapists that will work and actually have an elaborate sort of weaning down schedule. I just haven't found that beneficial unless, of course, it's patient driven. And so that's kind of the roadmap. I'll make sure I address my part of it, make sure that we address what's maybe causing it, and then have the patients kind of wean down in their own time. Now, you may not be able to get them off completely because it's, like I said, you have to pick your battles. But at least if I can half the dose or reduce the dose, especially if you bring up patients who've been on it for years and years and they start hitting their 60s and 70s, and that's when you're worried about how these sort of sedatives actually increase their risk of falls and self-harm. That's when I get concerned as well. So, I think we have to balance out that sort of scenario and then think to yourself, the next time I give Ambien, I want to make sure I set expectations for my patients as well. And then once you start using Ambien for more than 3 months and you start going to more of a chronic insomnia, that's when you start thinking about, oh, am I creating the next monster, Ambien monster? I don't mean to call them monsters, but you know what I mean.
Thank you.
Okay. Feel free to unmute and ask any questions. We have about a couple of minutes left. If not, I will go ahead and let y'all know that if anyone has any questions, just email us info@Sliiip. That's III. That was the cheapest way I could buy the word sleep without paying $1 million for it. And visit our website. We have a lot of cool resources, free resources for patients. I blog pretty often about sleep issues. My personal opinion is that I think a lot of health information needs to be democratized and delivered in a non-jargon like or a jargon-free manner. So there's a lot of my blogs there. There's also a lot of videos, teaching videos as well. So if you go to the website and you go under resources, you will see a lot of videos about teaching things like, how to address sleep issues and how to address pulmonary issues and even critical care medicine, which I'm boarded in as well. So, I'd love some feedback about that, but, feel free to reach out to us. We also have a referral tab as well on that. If you have any patients that need to be seen by us, we're right now licensed in several states. So feel free to reach out to us. Again, like I said, curbside, here to help. Let us know if we can be of any value of service to y'all.
Hi, Dr. Boris, Dr. John. Great talk.
Thank you.
One of our NPs, Rong, had a question about home sleep studies. Are you able to give a little information on how that usually works?
Sure. So, we're going to do the third session. We're doing a webinar on sleep apnea evaluation and testing, and we'll talk a lot more about that. But we generally, home sleep tests will fit most of the patients that you need information on. For example, a sleep evaluation. The only time I get really concerned is if someone has active arrhythmias, active chest issues or pulmonary issues, and neurological diseases, strokes, and so on, seizures, where the stroke patients won't be able to manage these things on their own. But the home sleep tests have gotten so much easier now that we actually ship them out to patients' homes. They get an email that has videos that show them how to use it. They have an insert on how to set it up. And it's 3 basic monitors. One monitors your oxygen level and your heart rate. Another one monitors your respiratory. It looks like a nasal cannula, but it monitors your oxygen or your respiratory flow. And the third is a chest wall belt that monitors your respiratory effort. So those 3 things get plugged into a little box. They switch, it turns green, you switch it on as you're going to sleep. You switch it off when you wake up. The only downside of home sleep tests, it tends to underestimate sleep apnea. And we know there's a lot of patients who get misdiagnosed and miscategorized. And so a lot of patients are like, oh, I only have mild sleep apnea. That can't be the cause of my sleep issues. Oh, it's mild. It can't be the cause of my heart disease. But in actual fact, there's a lot of these patients that actually have worse sleep apnea. It's just that when you captured it, it was considered mild. And don't forget how you calculate the severity of it is the number of events divided by the total number of recording hours. So if your recording hours is exceptionally high, so that's why I always take note of always the recording time. If it's like 8 hours, I've had patients who give the machine back to me with 10, 12, 10 hours, I think was the longest of recording time. And you ask them, I said, did you actually sleep for 10 hours? They're like, no, I got in bed and I switched it on. And so when you're watching TV and switching it on, that doesn't really count. So that's why home sleep tests tend to underestimate severity. And if you have a clinical diagnosis that this may be sleep apnea, is to either repeat the sleep testing or get them an in-lab study. So that's hopefully that answers the question.
Yes, great. Thank you.
Any questions, any thoughts? All right, folks, it's been fun. Hopefully this was a little bit more enjoyable than the inauguration because I know I was competing with that. But this has been great, and hopefully you all learned something, and we will send out those emails for the evaluation, the activity evaluation, and the webinar, the post-webinar test to get your credits. And that will be emailed out in a few hours. So just look out for that. And the registration as well for the 17th of February webinar will be out soon. So thank you very much and have a good day. Breathe well and sleep soundly.
Thanks, everyone.
Lee.